Dr. Meenakshi, okay, fine, no problem.
One second. Now we are on live.
Okay. Good evening to the monthly academic meet of TACO.
Sudha, just 1 second. Ma'am, can you just stop sharing the screen because we can't see the president?
Yeah, 1 second. Yeah.
So good evening to all of you. We are starting this month's academic meet with a very good program on childhood glaucoma, pediatric glaucoma, which, as you know, is an important cause of blindness. So coming to the World Sight Day, which was held yesterday, this is an important topic to continue on to that theme. So we will go on to that. Before that, I would just like to welcome her and let you know that this is a sponsored program through Alargan. So to introduce our speaker, Dr. Meenakshi, who is a dear friend of mine and a dear senior of mine at the same place in Delhi. So I'm very happy to have her here. Dr. Shikha will be introducing the speaker. Dr. Shikha, please. Dr. Shikha, are you online? Please unmute yourself.
Can you hear me, madam?
Yes, please.
Thank you, madam. A very good evening to one and all of you. We are lucky to have an eminent speaker with us today to enlighten our knowledge. A very happy welcome to Dr. Meenakshy Dhar, madam. She's a senior ophthalmologist who was a founder head of ophthalmology at Amata Institute of Medical Sciences, Cochin, where she spent over 2 decades. She hails from Delhi. She graduated from Maulana Azad Medical College and did a post-graduation from Guru Nanak Eye Center. She has done observership in pediatric ophthalmology at Jules Stein Eye Center at UCLA, California, and in oculoplastics and refractive surgery at Addenbrooke's Hospital in Cambridge in the UK. Her specialty interests include glaucoma, cataract, neuroophthalmology, pediatric ophthalmology, and squint. She has over 28 years of teaching experience as professor. She's a keen academician overseeing PT training for over 15 years. She has presented at various national as well as international fora, and she has got many publications to her credit. She has won AIOS Travel Training Fellowship in the year 1994, and she won the Best Poster Award at AIOS, which was conducted in Indore in the year 2019. So on behalf of TACO, we once again welcome you, madam. Over to you, madam.
Thank you, Shikha, for those kind words. And a very warm good evening to all my friends in Thrissur Ophthalmic Society. It's lovely to see all of your faces. Can't see you in person, and thank you, Sudha, for inviting me. It's a pleasure to be talking on something which is actually very close to my heart, is childhood glaucoma. Now I'm just trying to share my slides. Just bear with me, please. I hope all of you can see the slides.
Yes.
Thank you. So talking of childhood glaucoma, it is a heterogeneous group of diseases in childhood which share the final common pathway of ocular hypertension and irreversible pressure-related damage to the optic nerve. In these patients, timely and correct diagnosis is very paramount to ensure that the proper treatment is given to the children and they are able to retain their sight for life. And I'm very glad that on the occasion of World Sight Day, this topic is being discussed. It may present at birth or be diagnosed at any time during childhood. It's the sad part is that it is often misdiagnosed, missed, or mismanaged. In today's talk, we will be covering when to suspect, what qualifies this, what is the classification we follow, what are its clinical presentations, the pathogenesis, examination, treatment, and visual rehabilitation. So when to suspect congenital glaucoma, we had been told about that classical triad of epiphora, blepharospasm, and photophobia. That doesn't really often be the presentation in our country. Most patients in our country end up presenting as cloudy corneas, or they may have large eyes. They may also have pediatric cataracts if in the presence of rubella or Loeys syndrome. So there is a wonderful body of work which was done by the Childhood Glaucoma Research Network in 2013, which the World Glaucoma Association published as the consensus report. And it's a wonderful piece of academic reading on childhood glaucoma, which really updates it and talks to the point. So I would really recommend anybody who's interested to read it. So what is chaya? How do you define it? Now, it could be the presence of 2 or more of any of these following 7 characters. So it naturally needs to be present in a young person, less than 18 years. We know that at birth, the IOP is lower. So anything over 16 IOP is taken as a high in a newborn. Please do keep this in mind whenever looking at a small baby. Also, there is progressive increase in this cup disc ratio, which presents as a diffuse rim narrowing, and it does not follow the ISNT rule. And the good part is with treatment, it could be reversible. There could also be a cup disc asymmetry or a focal rim narrowing. And we all are familiar with the term HABS striae, which may be associated with childhood glaucoma, or an increase in corneal diameter. Here again, we need to remember that in a newborn, anything over 11 would be taken as an enlarged cornea, and 12 millimeter is the maximum that above which it will be in an infant, and at any age more than 30. Also, progressive myopia is a sign of childhood glaucoma or a reproducible field defect, which unfortunately you'll not be able to get, say, up to the age of 10, because children cannot really do this. And a patient is taken as a glaucoma suspect if only one of these is present. And we need to follow up these patients, and they may have a increased corneal diameter or excellence with a normal IOP. The classification which was given in this 9th World Glaucoma Association consensus would divided it into a primary and secondary childhood glaucoma. And it tries to discourage one from using terms like developmental glaucoma, infantile or congenital glaucoma. So in the primary, there is the primary congenital glaucoma, which is present in a younger age, or juvenile when it is present above 2 years. It could also be a secondary childhood glaucoma, where the glaucoma may be associated either with non-acquired ocular anomalies or non-acquired systemic anomalies, or it could be an acquired condition. And since practically every patient, every child who undergoes cataract surgery is prone to having glaucoma, so this is taken as a separate entity. In primary congenital glaucoma, we are used to the terms HABS striae, but the reason why this happens is because of trabecular dysgenesis. There could be also isolated angle anomalies or brush field spots as shown in the photograph right at the base, and there are gene associations present. It is found in 1 in 3,500 births in India, and it meets the definition of glaucoma with ocular enlargement, as the scleral rigidity at birth is very low. It is subdivided into neonatal type, which is if it presents between 0 to 1 month. And if it presents from 1 month to 24 months, it is categorized as infantile, and it is referred to as late onset or late recognized, spontaneously arrested primary congenital glaucoma. If with a normal IOP, you see findings of HABS striae or ophthalmos. We are familiar with the differential diagnosis. I will not go into detail. So each of these aspects, whether it's enlargement, haziness, epiphora, or the cupping, we need to rule out the other differential diagnosis. Coming to secondary glaucomas, it could be associated with non-acquired ocular anomalies like Rexenfield, Rieger anomaly, Peters anomaly, congenital ectropion uvea, in iris hypoplasia, which is congenital, and iridia, persistent fetal vasculature, ectopia lentis, oculodermal melanocytosis, PPD, microphthalmos, and microcornea. For instance, in Axenfeld anomaly, which is bilateral but asymmetrical, glaucoma is uncommon. One sees a posterior embryotoxon, and in these patients, and the strands of iris are attached much in it covers the angle structures, and it is inserted anteriorly. In patients who have Rieger's anomaly, it is autosomal dominant and has a bilateral but asymmetrical presentation. Glaucoma is present more often in 50%. One may see a stromal hypoplasia or a correctopia or ectropion uvea, or may see a full thickness iris atrophy. There are angle anomalies present with broad attachment of the iris tissue into the angle. It is referred to as a syndrome if there are systemic abnormalities, for instance, like dental and facial anomalies. Coming to Peters anomaly, again, glaucoma may be present in 50% of these patients. This, remember, is sporadic, and in bilateral in 80% of the patients. There is a corneal opacity with iris adhesions, and there could be lenticular adhesions as well, and there is glaucoma. Aniridia may have a varying incidence of glaucoma, and it could be anywhere between 6 to 75%. It could be a partial aniridia or a total, subtotal, or they could be even a synechial angle closure, or patients occasionally may have cataracts and lens subluxations. It could be associated with systemic implications. It is referred to as the Miller's syndrome. If it is accompanied with Wilms tumor or genitourinary anomalies and mental handicap. And if it is also accompanied with cerebellar ataxia in an autosomal recessive presentation, it could be in a case of Gillespie's syndrome. But most often, it is an isolated finding, which is autosomal dominant. Secondary glaucomas associated with non-acquired systemic disease or syndrome include chromosomal disorders, connective tissue disorders, metabolic disorders, phacomatoses, Rubinstein-Tyaby syndrome, or congenital rubella. In neurofibromatosis, the ipsilateral eye to the neurofibroma may have glaucoma. It is caused either by angle anomalies or with or without ectropion uvea, and the angle neurofibroma may also contribute to the occurrence of glaucoma. In patients of Sturge-Weber syndrome, that is encephalotrigeminal angiomatosis, glaucoma is intractable, present in 30 to 50% of patients. It is present on the side ipsilateral to the facial hemangioma. 50-60% of these patients may have the ophthalmos. There is a raised episcleral venous pressure, which is associated with the episcleral hemangiomas. Angle anomalies may also be present. There is a very high risk for surgery and a post-op choroidal detachment, and these are difficult to treat. There are rare things like oculodental digital dysplasia. This is one of our patients. who had these small teeth prone to caries, and she, by 16 or so, she had all implants and everything, thin nose, skeletal abnormalities. And she underwent a glaucoma surgery and is now a young lady who is, after one eye surgery, she migrated to US, and she's lost to follow. Rubella, unfortunately, in India is more common than in other places. And cataract and glaucoma can occur if the exposure occurs in the first 2 months to the disease. The infection, if it is the earlier the infection, the more severe is the disease. And the rubella IgM may be present, cataract also may be present, and hearing loss is the most common finding. Here again, there is goniodysgenesis, uveitis, or phacomorphic glaucoma may occur. This is one of our patients who was referred to us by Pete's Genetics, a 2-day-old child with, this is when I was at Amrita Institute of Medical Sciences. And the patient had a patent ductus arteriosus. My patient's diameter was 12 mm. It was hazy. IOP was 19. Patient was advised surgery and started on timolol 0.25%. Of course, the patient went doctor shopping, was diagnosed elsewhere as endothelial dystrophy, and came back to us a week later with IOPs of 30. And so this was a neonatal primary congenital glaucoma, which luckily, because of the setup that we have and the support we have from the systemic side and anesthesia, the same day there was the patent ductus arteriosus closure was done, as well as we did a bilateral trabeculotomy and trabeculectomy. The haze improved, the IOP decreased, corneal diameter decreased. Patient, I know at least for 2 years, post follow-up was well controlled, but of course is now lost to follow-up. There are glaucoma. Glaucoma can also occur in certain acquired conditions in children. If this present before 2 years, there's enlargement of globe, and beyond that, the globe is not enlarged. It could be uveitis, trauma, steroid-induced tumors, retinopathy of prematurity, or after cataract surgery, after surgery other than cataract surgery. Traumatic secondary glaucoma in children could cause a uveitis and lead to a glaucoma, could have a hyphema, which if very high can cause glaucoma, and if it is higher than 30, we may need to drain it. Patients of sickle cell disease bleed more often, and these children, it's very difficult to treat these children because we can't even use carbonic anhydrase inhibitors in them. Then again, you can have a ghost cell glaucoma causing or a dislocated lens or an angle recession. In penetrating trauma, also glaucoma can occur. And the early predictors of chronic post-traumatic glaucoma are high baseline IOP, gonioscopic pigmentation, hyphema, and angle recession of more than 180, lens injury, and absence of cycloglycolysis cleft on UBM. Beta blockers are the first line of treatment. Brimonidine cannot be given to less than 12 years. And then we come to an entity which is very often missed because the eye is quiet. Patient does not complain of anything except for a mild discomfort, maybe. For instance, this patient of ours, a boy of 10 years, came in 2013, and he had nephrotic syndrome, was on steroids. Vision was 6/6 and 6/12, but the IOP was 47 and 55. On visual fields, there was marked very advanced visual field loss, and one can see there was a high cup disc ratio. Patient could not be controlled with medication and had to undergo bilateral trabeculectomy with MMC, and the patient's steroid was stopped and other immunomodulatory agents were started. Coming to glaucoma in the setting of tumors, it may be the presenting sign. And other than leukocoria, it's probably the most common presentation. And there may be neovascularization of the iris, and it is predictive of choroidal invasion, and it means that enucleation may be needed. It could be the angle closure glaucoma due to a large tumor or an RD behind. And there may be obstruction of angle by the tumor cells. If in a patient of ophthalmos, you see a shallow AC, B-scan is a must to rule out any retinoblastoma there. There's a high association between high-risk pathology and elevated IOP. Of course, we can only medically manage these patients. Patients of juvenile xanthogranuloma can also have glaucoma, and one should suspect this if there are iris lesions and patient ends up having a spontaneous hyphema. One can do a skin biopsy to confirm it, and the treatment is medical with steroids and methotrexate and vinblastine. A setting in which we are finding glaucoma more and more because there is more and more ROP being diagnosed, and these patients may also have 3 time points when glaucoma can occur. They end up having a corneal haze, increase in corneal diameter, or shallow AC when the glaucoma appears. It could be associated with a laser treatment, and there it leads to an angle closure type of glaucoma. This may happen because of an anterior displacement of the lens iris diaphragm. This happens because there is thermal injury to the choroidal vasculature, and there is a choroidal congestion pushing the lens iris diaphragm anteriorly, or it could be due to ciliary body edema after the laser, or a hyphema or lenticular changes. It can also occur because of the choroidal detachment after excessive photocoagulation, or there could be a development of a retrolental mass. There could be a relative increase in lens thickness. There could also be a secondary angle closure and pass formation. So while managing ROP, please ensure that you get the IOP checked and look for corneal edema and AC depth. Another point, timeline in the treatment of these patients is when glaucoma occurs in the stage 4 or 5. Also, if ROP is untreated, there may be abnormal angle structures which may cause glaucoma, and of course, a neovascular glaucoma can also sometimes occur. The treatment could be either a PI, an angle surgery, or they may require trabeculectomy and GDP. This was one of our patients who was presented as a perforated corneal ulcer. There was an anterior staphyloma with corneal thinning, desmetocele, megalocornea, and a stretched limbus. In these patients, when the limbus is stretched, one has to be careful as to where, because the anatomical landmarks are distorted, one has to be careful while operating. Another setting in which we find glaucoma in children is after cataract surgery. Glaucoma develops in both aphakia and pseudophakia. There is a lifelong risk of patients having glaucoma, and hence IOP should be monitored at least once a year in children who have undergone cataract surgery. The younger the age at which cataract surgery is done, and in the presence of microcornea, the higher is the risk of glaucoma. Also, it could be the angle closure type of glaucoma if one has put a sulcus fixated PCI. But in fact, the open angle type of glaucoma is more common, and the CCT is high in these patients. It's difficult to treat. You can use beta blockers, carbonic anhydrase inhibitors, and we may need to use surgical glaucoma drainage devices. The trap with MMC may not work. Glaucoma and cataract coexist in patients of congenital rubella, as already mentioned, and in Loeys syndrome, also in aniridia and persistent fetal vasculature. So prior to congenital cataract surgery, please do evaluate the IOP and check the corneal diameter, lest you miss the glaucoma. The mechanism for glaucoma in these children could be the open type could be due to trabecular meshwork dysfunction, and because of the inflammation and cellular obstruction. It could also be steroid induced, because after the cataract surgery for a long time, maybe up to 6 months also, the children may be on topical steroids. Or another thing which happens is the insult to the developing angle structures from lens epithelial cells, and which reduces the outflow facility and may cause a developmental arrest as well. There's also a trabecular meshwork collapse from lack of ciliary body traction and can contribute to glaucoma. Patients may also have a synechial angle closure and lead to the closed type of glaucoma. So the key factors to monitor after cataract surgery in children to rule out glaucoma is: one is the IOP, the optic disc, look out for corneal edema, do the refraction, check the axial length. If it is increasing, think that maybe there is glaucoma occurring. And in older children, you can also do the visual fields, and whenever needed, do a UVA. Examination under anesthesia is a must pre-op and in the follow-up of very young children who will not cooperate. One can do it under chloral hydrate. When the eye pressure can be checked, best is with Perkins or Rebound, or you can even use a tonopen. Please remember to sedate a child, because in a crying child, the IOP may very often be erroneously high. So always either make the child sleep or do it under anesthesia. These children of congenital glaucoma, childhood glaucoma, may have a myopia which is increasing. They may have a fundus examination should always be done. Axial length should be measured each time when we are doing the EUA. If possible, do the gonioscopy, and a handheld slit lamp examination can be done as well. We need to remember the parameters in newborns and adults are very different. The axial length in a newborn is between 15 to 17, and it goes up to 23 to 24 in an adult. The corneal dia is around 9.5 to 10.5 at birth, and in normal adults ends up being as 12. Radius of corneal curvature also increases from 6.6 to 7.4 to 7.4 and 8.4. The keratometric value decreases and is as high as 51 at birth. The lens power also decreases. It may be as high as 34 at birth. IOP for children is between 12 and 16. So the proxies to elevated IOP, because the scleral rigidity is low, could be an enlarging corneal diameter, increasing length, axial length, and progressive myopia. So these can be indicators of glaucoma control. They could be a reversal of optic nerve cupping, and they could be stabilizing of the refractive error, axial length, and the corneal dia. The treatment is basically surgical in congenital glaucoma. The medical management is only till the patient can be made fit for surgery. It has unfavorable efficacy, high non-responder rate, and lack of long-term safety profile. The supportive treatment could be either timolol maleate 0.25% or dorzolamide. Avoid alpha-2 agonists. And if really need be, then one needs to give a prostaglandin. It's also medical treatment is an adjunct after surgery to control the IOP if uncontrolled. The first chance of surgery is the best chance, and one should ensure one can do the angle surgery, goniotomy if the cornea is clear, trabeculotomy, which may be conventional or circumferential. But the most common surgery that one does is the in India especially is the trabeculotomy with trabeculectomy. And it's more challenging than an adult surgery, and there is a high failure rate and more complications as well. The ideal surgery would be to keep a target IOP of 10 millimeters of mercury, and it should be something which lasts the patient's lifetime, and there should be no complications. It should maintain a good vision and complete it in a short time and achieve 100% success. The goal of surgery is to provide a lifetime of vision. They say this thing of 10:10:10 is the challenge for glaucoma, that a pressure of 10 millimeters for 10 years and the surgery is done in 10 minutes. And the more severe, in Indians, we have more severe glaucoma and earlier and it appears earlier, and they, depending on the IOP, one may decide, depending on the corneal diameter, one may decide the type of surgery. Up to 13 mm do a goniotomy or trabeculotomy. 13 to 16 mm do a trabeculotomy plus trabeculectomy or a glaucoma drainage device. And if it is very severe, we may have to resort to cyclophotocoagulation. So in goniotomy, it cannot be done if cornea is not clear, or there is severe BAS, or if the dia is more than 14 millimeters, as the Schlemm's canal in these patients is obliterated. In patients, is the video moving?
No, it's not moving.
I'll show the video at the end then.
Okay.
Yeah. So when a trabeculotomy, or shall I'll come out, stop sharing, and shall I see if it?
Yeah.
One second.
I think we can show at the end, then continue with it.
Okay. So in when we do the combined procedure, I'll hopefully show you the video at the end, or when we are having the discussion. So when we are doing the trabeculotomy plus trabeculectomy, we can actually see that during the surgery itself, the corneal haze may be disappearing. One use the arms trabectome, right and left, to do the trabeculotomy first and then complete the trabeculectomy. The glaucoma drainage devices may be used in patients who have a primary surgery for children with uveitis or aphakic or pseudophakic glaucoma, in Sturge-Weber syndrome, and in failed enhanced trabeculectomy. Also, it can maybe used in patients who have a lot of conjunctival scarring, where the sclera is very thin, or when there is very high failure rate, even with the MMC trabeculectomy. There is a higher chances of leak or endophthalmitis with the MMC blebs. One has to resort to cyclodestructive procedures in end-stage glaucoma, not done if central visual acuity is good. After failure of trabeculotomy or GDD surgery, in patients who are gravely ill, when follow-up and post-op care is not assured, or if there is a high risk for complications with intraocular surgery. Once we have done the surgery, the story just begins. We have to ensure that we follow up these patients. The first office exam is at 1 day, then 1 week, then 6th week. You should do an EUA again, and then follow it up with every 3 months EUA for at least up to 2 years, and a 6-monthly till adolescence. Each time when we do the EUA, there should be an IOP taken, the corneal dia should be taken, fundus, refraction, K reading, and axial length. So generally what I used to do is do the non-touch methods before you touch the cornea. So before you do the IOP, take the corneal dia, do the refraction, K reading, then do the IOP and the fundus, then do the IOP, then take the axial length. And if one keeps an Excel sheet and see how each parameter is going, one can assess whether there is good control or not. These children cannot speak, they cannot tell you that they are having pain, and they are mute spectators to their loss of vision. So we have to be more irresponsible and more vigilant that their IOP is controlled. Success rate for surgery for congenital and pediatric glaucoma, only about 50% patients reach adulthood with visual acuity of 20/200 or better. Especially this is in unilateral cases where there is also, it ends up with an isometropic amblyopia and because of the axial myopia. We say that a surgery is successful only when a child reaches the age of 8 to 10 with excellent central visual acuity. This is a brief decision tree to guide categorization according to the CGRN classification. So if a patient is diagnosed with glaucoma only after cataract surgery without pre-existing glaucoma, then you need to follow up the patient. If it is a glaucoma after cataract surgery, which could be due to any of these causes, or it could be that there was no cataract surgery done, then one has to look for congenital eye anomalies or systemic syndromes. If none of these systemic syndromes or congenital anomalies are present, we have to ask for history of trauma, uveitis, steroid use, tumor, ROP, etc. If these are not present, then it could be probably buophthalmos. And if it is a buophthalmos, we have to think of it as a primary OAG, which could be the neonatal, infantile, or late onset variety. And if the buophthalmos is not present, it means it's a juvenile open angular glaucoma. In case there is systemic involvement, then one has to rule out it could probably be one of the non-acquired systemic diseases or syndromes along with glaucoma. And if there is no systemic involvement, it could be one of the non-acquired ocular anomalies. Patients with the management of residual vision in pediatric glaucoma is very important. Very often they may have low vision and may need low vision aids for visual rehabilitation, like the telescopes and hand pocket magnifiers. Remember, they have a lifetime to go with this visual low vision. So we need to be very careful and look at and treat them and not neglect them. This CGRN classification is actually been a great game changer for childhood glaucoma. And this was an interesting article published in IGO, where when they did a retrospective study, and they found that 71% of diagnosis changed when one applied this classification. And one ended up with 23% primary glaucoma, 36% secondary, and rest were glaucoma suspects. So when should one refer patients? In infancy, when we see any signs of glaucoma, or when patients have conditions like aniridia or rubella. Very often in Amrita Institute, we were called for a hazy cornea. And they used to say that it is corneal exposure keratitis. So before you label a small baby as exposure keratitis, please remember to take the eye pressure, measure the corneal diameter, and if possible, if you can see the disc, please see the disc as well, and do not miss out a glaucoma in this setting. Also, if there is a family history of childhood glaucoma, and also check IOP in patients with congenital cataracts, as we know that the two may coexist. So the take-home message is keep the spectrum of glaucoma, childhood glaucoma in mind. It is very good that in the year 2019, they were actually trying to create a registry for childhood glaucoma, spearheaded by the Pediatric Glaucoma Association of India. And when we are operating these patients, we need to give meticulous attention to detail. And we need to have a good anesthesia support. So it's not that the surgery is something very difficult, but to operate a small child, we would need a good anesthesia support. There's a high potential for complications and failure, and we may need repeated interventions. And regular follow-up is a must. We don't, because we also need to keep the emotional and psychological aspects of the caregivers in mind. And our goal is to provide a lifetime of vision, a lifelong follow-up. And as I said, the 10:10:10 rule. Once considered virtually untreatable, childhood glaucomas have now become reasonably managed in most cases. These are some of my patients and which I treated at Amrita. Thank you for patient hearing. Now we'll come to the target IOP fixed drugs combinations, or would you like to discuss childhood glaucomas first while I take out the video? Dr. Sudha?
Can you put on the video right now? You'd like to see it.
Yeah. Just give me a minute, please.
Yeah. Very comprehensive talk and very well put.
Thank you so much.
We'll be going on to the discussion and then we'll go on to a second talk after that.
Sorry for this mess.
I think you'll have to share it separately, not the thing on the PowerPoint. Do you have the video separate?
Just give me 2 minutes or we can start the discussion. I'll just look for it till then.
Okay. I'd just like to ask one question. You said that all cataract cases have to be screened. So, right, when do you screen for glaucoma right after cataract surgery? How many days later will you look for the IOP rise? When do you usually see it?
I see. I would say that maybe after the two may have coexisted in its presentation itself. So the two may have been there initially itself. So we need to, or it could be when we at least take up the patient after, say, around 6 weeks would be a good time that we should be looking either before or after 6 weeks. And then at least after 3 months and then 6 monthly.
Okay, 6 monthly for life or yearly for life.
Yeah.
Okay. So you've seen it coming so early, right? 6 weeks after cataract surgery.
Yes, it does. The problem is that
unless we do an EUA, we won't be able to make out.
Yeah.
Mm-hmm. That is something I think most of us neglect. do the cataract surgery and say, okay, it's fine. And then we just think of the media clarity, but rather we forget to look at the intraocular pressure. Especially in infants, we tend to miss that.
Yeah. I don't know why it has stopped playing, because maybe I took it from one place to another.
Yeah, unless you have that video there, I don't think.
Yeah, I'll just look for it in case I can find it. Actually, it's a very clear video. It's sad that it's not playing just now. Any other questions?
What exactly do you mean by circumferential trabeculotomy? Do you do that?
Usually it is not something which is smart of you to catch on to that word. What can you do? What you can do is that on first stage you do at one side, and then later, if it is not controlled, you try to do it at another side.
Okay.
Meenakshi, because the video is not working, can you little explain what is trabeculotome or how you do trabeculotomy? Because most of the PGs might have never seen a trabeculotome, whether it is available or something like that.
Okay. I think I have a video of this is a 3-minute video. Can I play it? It
Yes.
seems to be an unedited 3-minute. Is it okay if I play?
Yes, yes.
Okay. Okay, I'll share the. My screen is not shared, na?
Not yet.
Okay. What was your question, Dr. Antharos?
A little more explanation regarding trabeculotome and the method of doing trabeculotomy.
Okay, so one makes an incision. These days, it could be an limbal or a conjunctival, a phonics-based corneal incision. Then one makes a triangular or a rectangular flap. Then one identifies, as you can see here, one has to do this step in high magnification and go very slowly. Can you see this? And when the moment you see this fluid coming out, yes, that means you have entered the Schlem's canal. Then you take the Ham's trabectome and put it on one side, and it will go through the Schlem's canal, and then you take it and you turn it around. Can you see in the top part of the thing? Yes. It has now entered into the anterior chamber. So the Schlem's canal has opened, and you can see that there will be a gush of fluid. So, and the same thing you follow on the other side. So there is, after that, this is what trabeculotomy is over. Abroad, they do just trabeculotomy and leave it. But in our situation, most of the patients come much later, and we have to do it with the trabeculectomy as well. And we do the trabeculectomy as just shown, that you make a small scleral deep to a total thickness tunnel and remove the trabecular meshwork. And you can see, as I don't know if you can appreciate, actually the cornea has cleared even just during the surgery from what we had started. And this is where I said, when we were doing the initial trabeculotomy incision, when the vertical incision, when it is made, the limbus may have stretched in patients who have megalocornea. So the landmarks may be a little distorted. I hope I've made myself clear in this.
Yes, yes, yes.
And so when I used to do limbal incisions, this was closed as a 2-layered thing. But now one can also, of course, do the phonics based. And also, if it is the blebs in small children are not very, if done properly, they are not always very, very large blebs. And one has to be very careful when one is using the mitomycin C. It should be only around 0.1% concentration. And it should be applied for 1 minute only and washed thoroughly. The key to MMC usage is that it should be thoroughly washed and the instruments should be changed. The instruments that you have been using while the MMC was applied should be put away, and you should use a different set of instruments for the following surgery. And also one should lavage wash the cul-de-sac, the conjunctival sac, with at least 15 to 20 cc of fluid. And so there are patients who, like, there is 1 or 2 children of mine of say NIDDO who have now become teenagers, and their vision is maintained. And it's a pleasure to see those patients. The blebs are luckily not too, I have not really come across very large or very thin blebs, thankfully. Any questions? I hope the surgery was clearer now.
Yes, sir.
Yes, it was very good video.
Madam, I have a doubt. How do you examine the child in the first day?
So,
after surgery?
Before surgery?
No, after surgery. The first day you said there's an examination, no?
Yeah. So first day after surgery, it is a very, our basic thing is that one is that we need, it should not be infected. As a general rule, we just separate the eyes and see that the cornea is clear or not, the AC is well formed or not. It's basically a torchlight examination, because it depends on the age of the patient. If it's like I showed you about a 2-day-old child, that is the youngest I've ever done. 14-day, not 2-day. 2-day it was at presentation. So the child may still be in ICU. So we don't resort to anything but a torchlight examination in the beginning. But there are few ways of examining children that they allow you to see the eye. One is that very often you can ask the mother to give the child while they are feeding with a bottle. So you can end up seeing. And I've seen generally that children up to say 1 year or so, they are actually more pliable to see. When they become a little more, they become older, that's when they start moving and they become more agile.
Okay, thank you.
And so your next examination is at 6 weeks. Your gonioscopy and all you will do at that time?
See, gonioscopy is not, gonioscopy I do in the, if it has to be done, should be done prior to the thing. We are not really achieving much by gonioscopy. And we actually didn't have a gonioscope, which was a deficiency that we did not have a gonioscope. But yes, of course, it should be used. But there is no need to do a gonioscopy unless if you need to revise your diagnosis or if you feel after the surgery. It's before the surgery that one needs to do it. But it's not that you can't treat a patient for childhood glaucoma without the gonioscope. In contrast to an adult where you can't think of doing glaucoma management without doing a gonioscope. Because here, either way, it is a surgical management in most patients. I can't hear you, Sudha.
Postoperatively, do we need medications for after this, like for glaucoma medications?
See, so what happens is you are anyway following the post-op regime for most often in our setting, we need to do a trabeculotomy plus trabeculectomy. Any patient, so there has to be antibiotics, there has to be steroids, antibiotics maybe for 1 bottle for 2 to 3 weeks only, or maybe longer, because if you have, since you have put sutures, there will be irritation. You try to, there is a balance between putting absorbable sutures to, or using the non-absorbable ones. So if it is absorbable, they tend to cause more inflammation also. So then steroids have to be used for a good 8 to 12 weeks. Then one needs to use the lubricants. One needs to use the cycloplegics. And as we are following up these patients, if we find that at 6 weeks or 3 months, it's not every other day that you are doing it, but at 6 weeks or 3 months, you are finding that the IOP is high, or if you have a reason to suspect it earlier, then you add, again, you start with timolol 0.25%. If that doesn't suffice, then you give them dorzolamide. And if that doesn't suffice, you can think of even revising your surgery, or and if that doesn't work, of course, you have to go in for a glaucoma drainage devices. You can use a latanoprost or any other prostaglandin analog as well. But in small children, it's best to confine yourself to timolol and dorzolamide. And actually, surprisingly, if your surgery is meticulous and you are careful, this trabeculotomy and trabeculectomy does work well. There was only one patient who had a very bad follow-up. Those are the patients that you end up having more of a problem. She didn't come, mother was not so convinced, came after 2 years. In fact, I just had to go and see the patient in an ICU. She was a syndromic child and she was probably on her last lap. So
you do bilateral surgery at one go?
I do. I used to do, like for this patient of rubella, there is no justification because the anesthesia risks are so high in a very small child. This will be one indication when I will do a bilateral surgery. But if I find that there is a difference between the two eyes, then I may withhold and see the follow up one eye. There were patients of ROP sometimes for whom I've operated one eye because it was advanced, and the other one continued on medication because it was not so high.
So any other questions, or we move on to the second talk? Yeah, Bastin, anything? Okay, shall we move on to the next talk then?
Yeah, actually, I did not keep it as a very long one. It's a very short with only 5-6 slides. Is that okay? Or shall I show the whole thing?
As you wish.
Thank you. Give me a minute, please. So coming to target IOP and fixed drug combinations, we know the target IOP at the time of diagnosis is very important. The recommended target IOPs as per the EGS guidelines are different depending on the type of glaucoma as well as the stage of glaucoma. So in general, the target IOP is lower in normal tensive glaucomas, and naturally it is lower in advanced glaucomas. And for instance, in early glaucomas of the POAG type with mean deviation loss of less than 6 decibels, less than 18 pressure is enough. While for an advanced glaucoma, you would require it to be less than 12 in primary open angle glaucoma. In NTG, even in early cases, you need the eye pressure to be less than 15. In a clinical practice, target IOP could either be a percentage or an absolute amount and of reduction that you want. It is a predetermined IOP or figure range. Both must be considered. IOP lowering strongly depends on the baseline pressure, and IOP reduced by more than 25% inhibits glaucoma progression. Target pressure should be individualized at the time of diagnosis, keeping the risk factors in mind, and it may need adjustment during the course of the disease. Now, how to set it? This diagram is something that we have been used to seeing for over now almost 2 decades, and but it's a beautiful thing which tells us as to where explains the concept of target IOP. A higher target IOP, that means you don't want to do so much lowering, is when there is an early glaucoma. And it's a lower target IOP, that means you want the IOP to be 10 or 12 in patients who have advanced glaucoma, in patients who are younger, who have a long time to go. So an 80-year-old with mild glaucoma, I'm not going to be so stringent about bringing it down, but for a young person, yes, of course, our target IOPs have to be lower. Again, it depends on at what IOP the patient presented before the treatment was started. If the patient IOP was already low, and in spite of a low IOP, the patient was losing visual fields and having glaucomatous changes, the target IOP has to be still lower. If there are additional risk factors, target IOP needs to be lower. And if there is a rate of progression in spite of treatment, and then the target IOP has to be again brought down. Progress needs to be continually monitored against the target, and depending on the patient's response to treatment, the physician must use their clinical judgment to set a higher or a lower target IOP. Now, there is, if we should determine individualized target IOP and prescribe the treatment accordingly and reevaluate for progression. If the patient is stable, well and good, follow up for 6 months. And if the patient continues to be stable, we can reevaluate after 6 to 12 months. On the other hand, if the target IOP is not reached, consider accepting higher target IOP and reevaluate. If there is progression, consider lowering the IOP. And if either it could be that you add another drug or you use a combination therapy. And if the target IOP is not reached, then you can substitute the second drug and verify its efficacy and tolerability. Or we may have to resort to other options of management, and like surgery or lasers. One should periodically verify the endpoints, the visual fields, disc changes, the IOP, and ensure that the quality of life is maintained. When we use a single drug or a combination, which is more effective? It's the combination which is more effective. For instance, if one uses a beta-metoprost as well as a timolol separately, The decrease in IOP is maximum around -0.8, -8.4 at 2 weeks and 8.1 at 3 months. So combination is more effective in lowering mean IOP from baseline and clinically and statistically superior to each constituent. The and bimatoprost and timolol instilled together produce a significantly greater IOP lowering effect. And then if it's a combination of latanoprost and timolol, this was published by Martinez in 2009 in I. Also, it has been found in other studies by Lee et al. That the fixed drug combination of bimatoprost timolol statistically significant reduction is less. There is more reduction with this combination than if one uses travoprost timolol combination. Then again, the changes in IOP with dorzolamide timolol combination is much less. For instance, here in baseline, the bimatoprost timolol group, it was 28.5. It came down at first review to 20 and second review to 15.5, and which was less than when patients were put on dorzolamide timolol. This was published in the Indian Journal of Pharmacology in 2010. So reduction in IOP was higher with the bimatoprost timolol combination. So once a patient is diagnosed of glaucoma, characterizing a risk profile is useful to plan an individualized management strategy. Main factors are the visual field damage and intraocular pressure. Target pressure should be accordingly estimated. Patients showing a meaningful risk profile may benefit from an earlier and lower IOP reduction with a medical treatment. Highest efficacy is achieved with prostaglandin analogs. Among them, bimatoprost is the most efficacious one while preserving a good tolerability profile. And at follow-up, early and fast progressors should be separated, and patients who are fast progressors, there should be an earlier intervention and ensure that this progression is halted. And when you give a fixed bimatoprost timolol fixed drug combination, the results are good. Thank you for patient hearing. I'll stop sharing my slides.
Thank
Sorry,
you, Dr.
It has been a very long monologue. I don't know how many people would have slept off on the Zoom.
Oh no, I think there are good enough attendees. They're all listening very carefully.
Thank you so much for patiently listening.
So this topic, I think we've had some kind of a discussion already before this, fixed drugs combination. We won't go on to this. I think we go on to Dr. Sujata. Will you please give the vote of thanks?
Thank you, Sudha. Good evening, Manandar. I would like to offer a vote of thanks. I thank Professor Dr. Meenakshy Dhar for her instructive presentations. Childhood glaucoma is always a gray area for all of us, and you have made it so clear for us. And we are so happy to see you again, madam, as we are, most of us know you so well during your Amrita days. I thank you on the behalf of every TACO member.
Thank you.
And I thank all the senior faculty who are attended and supported us. I thank each and every person who attended and made this meet a grand success. Then I also thank Allergan companies for their sponsorship. I thank Dr. Bastin and KSOS for the technical support and offering the Zoom platform. I thank everyone once again. Thank you so much.